Doctors, we are live. You can start the session.
Okay. Hello and welcome everyone for this live webinar show by Glaucoma Society of India. And this is Dr. Satyan. Today we have our international speaker, a wonderful personality, Dr. Pradeep Ramulu. First of all, our sincere thanks to you, Dr. Pradeep, for accepting our invitation to be a speaker for today's session. Without much delay, I would request Dr. Kavita to introduce our good friend, Dr. Pradeep. Dr. Kavita,
Thank you,
please
sir.
introduce Dr. Pradeep.
Thank you, sir. Thanks for that opportunity to introduce my mentor. It's my pleasure to introduce a great person, a great teacher, Dr. Pradeep Ramulu. He graduated with honors from Stanford and completed his MD PhD at Johns Hopkins with a PhD in retinal biology, followed by residency at Wilmer Eye Institute and a glaucoma fellowship from the very famous Bascom Palmer Eye Institute. His key areas of research includes the functional consequences of visual impairment, particularly disability and fall prevention. And he's a voracious researcher who have authored more than 250 peer-reviewed papers, multiple textbook chapters, and 2 books to his credit. And he's a very, very busy person. As you can see here, he holds key positions in major organizations, including American Glaucoma Society, World Glaucoma Association, AAO, and NEI Council. Is the past program chair and the future president for the American Glaucoma Society. He's a dedicated teacher, educator, who has mentored numerous trainees and faculty, introduced innovative online learning tools, and won the Resident Teaching Award twice. And we are thankful to you for introducing some of these teaching tools to us when you are visited Arvind. And I think the Kahoot quiz is the one which is like we are using till date, and people really enjoy that. And he has received a lot of recognitions, and he has consistently been funded by NIH since 2007, and he has received prestigious awards, including those from AAO and the PISAT Award. And he's a great personality who balances clinical excellence with groundbreaking research and leadership in glaucoma care. Currently, he serves as a director of the Wilmer Glaucoma Service at Johns Hopkins Institute, consisting of 10 faculty and 20 research, clinical, and administrative staff members. Over to you, sir. Looking forward to listening to your talk.
Thank you so much, Kavita. Dr. Pradeep, we welcome you.
Okay, well, thank you for the invitation, and Kavita, thank you for that wonderful introduction. It's really an honor to be here, and I hope soon I get to meet all of you on the leadership and many of you who are listening in person as well. So I'm going to talk about uncertainty in clinical practice and how it kind of manifests itself, and give you some ideas about how we might deal with it. There's really a lot about glaucoma we don't know, and it really infiltrates quite extensively into how we treat individual patients. These are my disclosures. Since I am incoming president of the AGS, I'm actually not taking any more consultant roles with companies, but I do have some that were from the past, and I do have some industry support for our research as well. This is kind of the amount of that support as well, and this is visible in the US on the Open Payments website. So, when you come to meetings or, you come to webinars, I think the reason we do that is really to be more certain or correct in the decisions that we make clinically when we interact with patients. And so this is from our AAO meeting last year, a few sessions about, elevating your clinical practice with clinical trials, deciding what surgery you should do next if something doesn't work, or, how we should handle specific clinical situations such as a primary angle closure suspect or early glaucoma. So, we come to these webinars to be better at, how we handle these situations. But, the reality is that, when we are trying to make decisions on individual people, we have to be confident in the information we have in order to make that decision. And, I think that all the information that we know and all the papers that we publish don't tell you what's going to happen to an individual person. They tell you what happens in groups of people. And of course, that person who you're treating is part of that group, but they're not exactly the group. They're going to be different in many ways that we can't, elucidate. I think, being from India, a lot of the trials that you may study are from totally different populations, not only genetically, but also people who have very different systems of healthcare and, who may have very different lifestyles and diet. And, to what extent can you extend that information to your own population? Even if you had an information about your own specific population, the truth is that there's a lot of individual uncertainty about what's going to happen to one person within that population, even if you know what's going to happen to the specific population that you care for. And I think, the question is, how we deal with this uncertainty at the level of the person, based on what we think we know about the population really has tremendous implications. This was from our American Glaucoma Society lecture last year in 2024. And I thought it was a very, very good lecture by Jamie Brandt, who's at the University of California, Davis, who gave a lecture on the worried well and why and how we're overdiagnosing and diagnosing and overtreating glaucoma, and why this is an issue and also a potential problem, not only at the individual level, but at the societal level. And I wanted to kind of, bring up this topic, the worried well, because, it really implies that it's that person, the patient who is driving over treatment. And that, this person, and it's kind of, a little bit disparaging that person and saying that they shouldn't be worried and that worry is not a legitimate part of the condition. But, when people are worried, we have to ask ourselves, where does this worry come from? I actually like the term the worried well-meaning much better as a driver of the problems that we see with overtreatment, because it's not necessarily the person who is the problem, because oftentimes their worry is generated by what they hear from society or what they hear from providers, but it's actually the medical community which actually is the one delivering the care, and so they are in many ways the ones who are driving the overtreatment. And I'd like to also make a thesis about, why providers overtreat. And I think a lot of us overtreat, because of uncertainty and our inability to handle that uncertainty in a healthy manner. So this is a review article that discussed like the drivers of overtreatment and both overdiagnosis and overtreatment. And it wasn't related to ophthalmology, it was related to medicine in general. But I think it still has a lot to teach us. And if you kind of summarize, these drivers of overdiagnosis and overtreatment, they really come from uncertainty in whether somebody has the condition or not. What the testing and imaging say. So, what are the results of our testing and imaging? How likely a therapy is going to be. And, what is this going to do to the individual person? So these are really the drivers of uncertainty when we don't know whether somebody has a condition, what our tests are saying about their presence of the condition or the severity of the condition, and how likely our therapy is going to be, then, we always have a tendency to do more because we don't really know what the situation is. So we say, well, let's err on the side of being conservative and doing a bit more than we might, just to be sure. And so this is certainly one approach to dealing with clinical uncertainty, to say, well, I don't really know what's going on over here, so why don't I do a little bit extra? Because what's the harm in doing a little bit extra? And it sounds like a good idea. And in fact, in the US, this has kind of come about, and you'll see it in a lot of the, in the trade journals and like, the journals that are sent through the mail to all the providers, where it says, oh, for glaucoma, we should have an interventional mindset. And it's something which sounds very good, on paper. It says that we should take a proactive approach to treating people with early intervention, patient-centered care, and a variety of options. And so, of course, right, who can argue with these things that, you should intervene early, that you should be patient-centric, that you should use a variety of treatment options, and that you should, reduce medication burden, so it's hard to really argue with it presented over here. I think the issue is, does this encourage us to do too much? There are studies with patients that actually ask them, how they would prefer to approach their medical treatment. And this is one example of it. It's called The Decision Is Yours. And it really explored attitudes about overtreatment. And it is quite interesting. on the one hand, people really want to know if they have a problem. So they want to get testing and screening, and they really like it when this testing and screening is with advanced technology, because it helps prevent things if you know that you have them early. On the other hand, they don't like too much treatment. So, at least in the US, people are a bit cynical about all the systems, and they think that physicians are being pressured by drug companies and are being pushed to do what they want to do, or that they're profit-minded and things like that. So they don't want too much treatment either. So especially with medications. So why not to really kind of screen people aggressively, even if it means overtreating some people. I guess these are some reasons why not. Whenever we do that, we are generating cost for society. We may not really see it, and we may even benefit from it in some ways, but it's still causing, a cost which maybe could have been spent somewhere else. I think it kind of denigrates ourselves as an important resource, that we really need to see ourselves as something which is very important and is hard to replace, and that it's limited. And I think it also, we need to think about our legacy as what a provider is. And I think finally, I think it's the easy way out to often say, well, I'll just be, always err on the side of being aggressive. It doesn't require a lot of thought. It doesn't really require a lot of consideration of what the patient's course is going to be. And it's easy to say, well, let's just do a little bit extra because we don't want this person to go blind for something that, for some level of undertreatment. The truth is, in the US, if you look at it, that the medical overtreatment creates a very considerable societal burden. 30% of healthcare costs in the US are due to overtreatment. And so, this is money that could have been redirected towards people who needed the care. Even in the US, the cost of healthcare are crippling to the country. In the US, it's really 17% of our overall expenditures. And, we're really one of the outliers, but, in many places, healthcare costs a lot of money, and it can be quite expensive for people. Even in the US where you say, oh, there's plenty of doctors, actually there's still probably not even enough doctors, and this is going to get worse. So, we have fewer doctors than some other countries. And I think if you look at workforce projections, all of us are going to get busier than we are in the future because there's more people who are getting old, and there's fewer physicians because people retire a little bit earlier, and some people don't want to work at the same level or intensity that people worked in the past. So, we're getting to the point where even right now, we don't have a lot of people working in some rural areas. And in the future, this is going to get even worse, and all of us are going to have to take care of more people. And many of us are already quite busy right now. And of course, we're in a very privileged position. So this shows the density of ophthalmologists by country. And the US is, one of the top ones. But, if you look at a country like India, there's very few ophthalmologists who have to deliver a lot of care. So to the extent that care is being delivered for people who don't need it, it's taking away the opportunity to treat people who do need it. I think most importantly, you have to really think about, why did you go into this field and what are you really trying to achieve? There's one option to say like, hey, well, why don't we treat everybody aggressively? Some who would clearly benefit, many others who would have had a benign course, and, probably didn't really benefit at all from what you did. Or do you want to say like, oh, let's be selective in the treatments we deliver, and leave as much room as possible to help those who are unlikely to do well and really make the maximum difference for those individuals. I think we can get better at communicating uncertainty. So this is, one example in the US where, oftentimes we will follow people with ocular hypertension, and in the setting of, good follow-up, and probably some of you have at least some of that in your practice, you can display things, you can tell people very different things. You can tell them that you have a high eye pressure, which is a strong risk factor for a sight-threatening condition, which is irreversible. And so you're recommending early treatment. Or you can tell them something which is quite different. You can say that you have a high eye pressure, which can produce a disease, but it hasn't produced that disease yet. And that many people with high pressures never lose vision. And that we can pick up changes well before it causes any visual changes in you. And then we can start treatment then. And of course, emphasize that you have to see them. This may not be the right message for somebody who's in a very rural setting and has a very low likelihood of following up. Satya, I remember you told me once that 90% of patients who you did surgery on, were not following up within a year. So, this may not be the right message for them, but for somebody who is likely to follow up, you can give them two very different talks, which would lead to very different outcomes. Glaucoma is a little bit different than other parts of medicine in terms of dealing with uncertainty. So a lot of medicine, screens or treats for things that are discrete outcomes. In other words, you have to control somebody's blood pressure so they don't have a stroke or a heart attack, or you have to do a colonoscopy so they don't get a cancer, or you have to get a mammogram so they don't get a cancer. But it's not like that in glaucoma because, we don't have these yes or no things, cancer, stroke, heart attack, these are yes or no items. But, we are able to stage our disease pretty well with OCT and visual fields and clinical exam. So it's really quite different. We can really say where people are in the spectrum of disease. And even before the disease starts with OCT. So the thesis here is that we're part of the worried well-meaning because we tend to overtreat people because of worries about poor outcomes. And uncertainty in our measurements tends to really stoke these worries. And I think the better we understand, the better we learn how to deal with uncertainty, the more we're able to allocate our resources and our efforts to people who would really benefit from them the most. So I want to talk to you about uncertainty, as it relates to our measurements, and then when we can tolerate uncertainty and when we should be more interventional with regards to uncertainty. And, how do we kind of decide between, in these kind of borderline cases, can we do something to decide between kind of the more conservative approach and the more interventional approach? I was going to start with diagnosing and starting treatment for glaucoma, and first talk about the level of uncertainty in our measurements. I mean, the truth is that even today, we don't always know who has glaucoma and who doesn't. This is a project that was done by my colleague Harry Quigley and Bal Shahan, where they took a bunch of submitted patient data, and then they had glaucoma specialists grade the likelihood that that person did or didn't have glaucoma. And, what you see is that, there's some people who, everybody felt didn't have glaucoma, and put everybody at the 0% likelihood. And then there's people who almost everybody thought had glaucoma, but then there's people where people didn't really know. And, this is a good case. The optic nerve looks like it's a little bit cupped, inferiorly, but there is some peripapillary atrophy over there, which can sometimes mean that it's tilted in that direction, causing the appearance of cupping. And of course, they have a superior defect, which goes along with it. But then their OCT, including their macular OCT, which often tends to overcall things, is really quite normal. So, do they have glaucoma? Do they not have glaucoma? I mean, I think it's easy to have a lot of equipoise or uncertainty here. Well, how do we deal with this uncertainty, and when do we decide what we're going to do? Well, I think we have to think about what is the impact of treating or not treating or under-treating somebody. And, there's some people who I think we can be more conservative on, people who there's no evidence for functional impairment, for example, and people who have periparometric disease. So the person's not affected by their disease right now, at least. Even in people with unilateral visual field damage, the impact on their well-being is pretty mild. And this shows a number of, a kind of a quality of life questionnaire where they compared individuals with no visual field loss to mild loss, and shows that, the quality of life is very, very similar. And only when you really have, bilateral visual field damage, and really only until you have the more moderate and severe levels of bilateral visual field damage, do you really see a decrement in their quality of life. And so, I mean, this is one of the few things that we found that actually was affected by unilateral visual field damage, and that thus individuals were more likely to have stopped driving if they had unilateral field loss. I mean, there's certainly a lot of classic literature which tells us when conservative care can be appropriate, especially for people who are going to continue to follow up. This is Anders Heil's work from the early manifest glaucoma trial, which showed that certainly pseudoexfoliation patients, tend to have very rapid rates of progression and should be treated aggressively. But if you look at the non-exfoliatives who had an average pressure of less than 21, especially when they were younger, the average rate of progression was 0. So they didn't progress at all, even over many years of follow-up. In the collaborative normal tension glaucoma study, they actually found that most people had, relatively slow rates of worsening, less than, half a decibel of worsening or less, and very few people, worsened at a very high rate of change. So, if progression is slow in cases such as these, such as, for example, younger normal tensives, And you add on top of that you may have an uncertain glaucoma diagnosis. And we know that even if you get glaucoma, that the early impact is mild. I think being less intensive in our therapy or even not applying any therapy at all becomes a reasonable option. I think we often tend to overtreat, based on IOP. And I think that, we don't realize the level of uncertainty even in that IOP number. So this is a study that I did with my colleague David Friedman and Alex Mihailovich, where we actually had both of us in a blinded fashion check the eye pressure on the same day for the same patients. And it was somewhat surprising, how often patients had a disagreement between the two of us of over 2 millimeters of mercury, and occasionally even over 3 millimeters of mercury. And this is even greater if we compared ourselves to the technician. So at least we as physicians tended to get more consistent readings. But the truth is that these numbers that we get are probably estimates of what the pressure are and not the precise pressure itself. So I think when you take single measures of a slightly higher IOP, you have to always keep in mind that this may not really actually even really be a high IOP. I think this becomes even more problematic if you start using different measurements or different methods for measuring IOP. This is a current student of mine, Wendy Xi, who actually looked at 100,000 encounters in which the eye pressure was measured by two methods. And while the average difference between these methods is 0 because everybody has calibrated their readings to Goldmann applanation, the frequency of disagreement by more than 2 millimeters is pretty high. This is for Goldmann versus eye care, Goldmann versus tonopen, Goldmann versus ocular response analyzer, so a type of pneumotonometer. So really you get pretty different readings by all of these. And so when you start introducing all these, you realize just the degree of variability that eye pressure measurement can have. Well, how do we deal with this uncertainty, and how do we proceed with it, and when should we be more interventional about a high pressure? I think this is work that my colleague Jithan Yohannan did, which is very nice. So he actually looked at how the relationship of IOP was to progression, either when you treated IOP as an absolute number or you treated IOP relative to a target pressure or a goal pressure that a physician had set. And if you just look at the relationship between mean IOP and the rate of change in somebody's glaucoma over time, you didn't see a relationship. But if you looked at the relationship of pressure to the target pressure, so in other words, the difference between the observed pressure and the target pressure over the course of follow-up and how that related to their change in mean deviation in their visual fields over time, you found a pretty significant difference. So in other words, a target pressure that a doctor would set, and these are not very difficult to set, actually makes a difference. So if you're somebody who's well below or well above target, it may not really matter how, whether this, measurement uncertainty is there. But if somebody is, right around target, being off by 1 millimeter or 2 can really make a big difference. We think that we know whether a treatment has worked. So if you start somebody on a medication or you do a laser, you think that you really have a good idea whether that medication has worked or not. But the reality is that we really don't know. This is my colleague, Tom Johnson, who worked with our former resident and fellow, Jasdeep Sabrawal. And he actually looked at a washout of individuals, or a single individual in this case, who was using latanoprost, and the pressure went up from 12 to 16. But, they did this in the setting of a home tonometer where somebody was checking their pressure at home using a home version of the eye care device. And what they found is that if you actually just took a single reading before and a single reading after, and then you looked at the distribution of results that you can get, 12% of the time, you would actually conclude that the latanoprost did nothing, or that it even increased the pressure. And and some of the times you would impute a much greater impact than there actually was. So we think that we actually know what's happening when we start medications, but I think we're often surprised that sometimes these can be quite wrong also. This variability is probably even greater when we're talking about third or fourth medications. This is work that my colleague Tom and Henry did with the washout of these are data from the washout of the Hydrus trial. And they actually found that, when you wash out one medication, pressure goes up by 6 millimeters of mercury, but you don't get that much extra if you wash out even more medications. So if you look at kind of on average, what is the additional impact of an additional medication beyond the first medication going to be? It's only going to be like, 1 or 2 millimeters. And so are you really going to see that extra effect, especially in the setting of what we know to be a variable measurement? So how do we really know whether IOP is safe or unsafe, and what we should do about it? I think that a lot of times we make decisions based on incomplete information, but there are certain situations where we can define IOP better, and this is some of the approach that the U.S. has been taking. So if somebody has, for an example, occasional IOPs above or well above the target, or they have controlled IOPs on treatment but a very high IOP baseline, or there's a lot of disagreement between IOB and either their symptomatic change or the change in images and visual fields. I think we've often started moving to home tonometry, where we can get a much more complete assessment of what that person's IOP is. So this is a study that my colleagues Tom Johnson and Elise McGlumphy did, where they actually compared the pressure measured using this home eye care device, where patients have to self-apply and self-measure their IOP using the home rebound tonometer. And they did it 4 times a day for 7 days. And we can compare that to the mean clinic IOP. And what you see is that the correlation, while reasonable, shows an R-squared of only 0.41. So they're not super correlated. And so I think oftentimes we do see patients who give very different readings, which drastically change what our decision would be. This is one example of it. This is an individual with pseudoexfoliation, baseline pressures of 30, and they came in with treated IOPs of 13 and 11, and somebody else had recommended them for cataract surgery with a minimally invasive glaucoma procedure. And so we said, well, your pressure is actually pretty good, but you do have pseudoexfoliation, which is a high-risk disease. And, you started off with a pretty high pressure. So, why don't we just get a home tonometry trial on you? And what we found is that, they were actually having pressures that were quite high, routinely going up into the 20s, usually early in the mornings, but sometimes even in the evenings. And this is on a regimen of Vyzulta and Timolol. They were convinced that, like, okay, actually changing the timing of the medications would help. So we changed the timing of the medications. But then after a while, it actually didn't seem to make any difference. And so it started going back up again. So, I think that, these 11 and 13 were really quite deceiving and didn't really paint a whole picture of what was happening. So, eye pressures can miss out of control spikes in IOP. And so we've started moving in the US, where there's the resources to do this, to actually taking people who are where the clinical data and their clinic data don't seem to match up, and oftentimes considering this to decide whether they need surgery or a more interventional approach. Well, what about visual field testing and using visual field testing to deciding whether we need to advance therapy? This is mainly for people who are coming in for routine follow-up. Well, visual fields are pretty variable, as we all know, and maybe even more variable in some parts of the world than others. And they can fluctuate a lot. So, in the US, these are the results. And this shows in people who had a series of fields that about 5% of fields, will vary 2% from 2 decibels from the trend line in mild disease. And in moderate or severe disease, about 5% will vary more than 3 decibels from the trend line. The trend line being, the kind of the linear slope through all the mean deviations. We think that we can kind of capture all this by looking at the reliability measures of a visual field, but in fact, we really can't. This is work that Jithan and I did very early in his career, where we actually looked at the reliability measures of a CETA standard visual field and found that fixation losses could not really at all predict, the degree of visual field loss. And false negatives could, but, in order to get a decibel of error, and I'm telling you that many people have 2 to 3 decibels of error without any problems, you really need to have a lot of false negatives, especially in moderate and severe disease. Longer tests can cause it, and false positives can, but usually only when you have a fair number of false positives. I think the problem is that that even people who have a test that looks like it's pretty good can actually sometimes have a result which is, well off of what is probably true. So, here we looked at the likelihood that somebody would have a visual field where the mean deviation that was observed was more than 1 decibel better than the mean deviation that would be predicted by all the other visual fields that the person did. And we found that about 15% of people would have an unexpectedly good visual field, even if they didn't have any problems in the visual field. There were no false positives, no false negatives, no fixation losses, etc. And similar results were seen for people with unexpectedly poor sensitivity as well. So there can really even be a lot of uncertainty in reliable visual fields. This is very nice work that Jithin did, where he tried to figure out the best strategy to understand what a person's next visual field would be based on their past visual field. So, one way is to say like, well, I'm going to take all the unreliable visual fields and I'm just going to ignore them and throw them out. That's actually what did the worst. So that created like the most error in the predicted visual field. If you simply used all the data, you did remarkably better. And if you start using more advanced algorithms to kind of figure it out, you do a little bit better than that, but not much better. So, really, you have to really look at all the information, even the information which you think may not be fully reliable. Well, when we see something which is on a visual field, and these are people who'd had a series of visual fields, when can we, say like, well, maybe this is uncertain and may not be real, and when should we be more aggressive as a result of it? I think that we really have to be using all the information given to us, not just the visual field by itself, and not look at it, in isolation. So if you have somebody, for example, whose visual field or OCT is worse and it's a good test and it's not highly variable, but if the pressure is controlled and the patient is not symptomatically worse, I mean, I think it's certainly well within our rights to keep following them as we normally would, or if you're really concerned, you can repeat testing sooner. And certainly the ocular hypertension treatment study bears this out, that a lot of the people who converted to a visual field endpoint in the study, many of them actually would go back and continue to have reliable tests afterwards. So you really needed to have multiple consecutive abnormal tests before you could really be sure that they were worsening. This is another strategy if you're not sure the visual field is worse or not, but it's the one that's really difficult to achieve. So, if you have a visual field that looks worse, but you have a pressure, for example, that's sometimes above target, but sometimes not, but they're symptomatically stable, I think you can get what I said before. You can get a home tonometry trial, or if that's difficult for you, a diurnal curve, or just repeat IOP readings to decide what you're going to do. On the other hand, if the pressure is controlled, but they're symptomatically worse, I think it's really important to kind of bring out, well, what are the symptoms of glaucoma? And can I believe that this really reflects what's happening to the patient? So I think you have to be able to do a serious assessment of a patient's function and symptoms. This is work by one of our current residents, Yesha Shah, who actually kind of talked about the symptoms that correlate most with disease severity in glaucoma. And I was surprised by how well these do, and I have incorporated this into my practice, and I use them all the time. So she found that, first of all, somewhat surprisingly, that you could predict a lot of somebody's severity if you ask them about either the frequency or severity of a small number of symptoms. And in fact, that this question about their symptoms could predict their severity, better than even an OCT did. So it's actually a pretty good predictor. Well, what are these symptoms? I think the one that came up quite a bit was cloudy vision, that predicted people who described that, especially to a severe degree, really had much worse vision. And the other one, which certainly makes sense, although something that I was never really talking to people about, was missing patches of vision as well. Having little peripheral vision is there as well, although honestly, we tell people that they're taking a test of their peripheral vision and they may read ahead of time that glaucoma is a disease of the peripheral vision. So I wonder whether this is really, something that's actually happening in their lives, or whether they're just saying it because that's what they think the disease is. So I use the words cloudy and missing patches all the time when I'm talking to patients. When I have a person sitting in front of me, for the first time, and they come in, newly diagnosed with, very advanced glaucoma, I tell them, oh, it must be terrible for you. You must feel like you're looking through a bad cloud or a fog all the time. And, they will nod their head and say, yes, yes, yes. So, it really helps you communicate better with patients. And I think it helps you tell people what's going to happen if their disease is not treated properly, that cloudiness is going to get worse to the point they're going to have trouble seeing anything. I also like asking about symptoms and discussing them because they really are the patient's truth. And so I spend a lot of time talking about them. And I think when symptoms are worse, if a patient comes in to tell you, doctor, I'm seeing worse and worse, I'm having trouble seeing, reading, working, etc., it certainly gives you greater license and greater comfort in advancing therapy. And patients are likely going to want an interventional approach. If patients' symptoms are not worsening, they're going to accept less risk, and they're going to be very upset with you if you do something which disturbs them, even in ways that are pretty minor. So if you do something that makes their eyes more dry or their refraction not right. And so I tend to consider a conservative approach more strongly. And you really have to spend more time talking to them about why they should do something which has risk when they may not feel like they're having a problem right now. If you really want to confirm whether a visual field has changed, there are sophisticated ways of doing it, but it is quite intensive. So this is a nice algorithm that David Crabb approached, where he could show that instead of doing a number of tests with even spacing, if you cluster those tests at the beginning and the end of the follow-up period, you actually do much better. You're able to improve the likelihood and the power to detect and reduce the number of false positives with regards to disease detection or worsening detection. The problem is that, is this really practical? And so, I think that, one somewhat more practical strategy would be to do a visual field every 3 months, 3 times, wait a year, and then do it again. But this is certainly a lot of work and takes up a lot of resources and may not be practical for patients who are coming from a large distance. This is a nice strategy that's been suggested for patients who live distantly. This is work from Australia by Jack Fu and colleagues, where they actually did multiple tests on the same day. So they did, 2 C-to faster tests, and people who are progressing very quickly, even with yearly testing, you can get an 85% reliability progression or specificity, within just a couple of years, by doing multiple tests every time somebody comes in. Again, a lot of work when they come in, but they don't have to come in very often. And you do see quite an improvement. I think finally, I want to talk a little bit about, why patients come to see you. So this may be people who are a little bit more on the demanding side and come to see you. And, what should you talk to them about? How can you improve their quality of life? There's really a lot that we have to discuss when patients come in to see us. And, these are visits that are often very short, 5 minutes, 10 minutes. And, many of these things we have to talk about, what are we going to treat them with? When are they going to follow up? Do they need a surgery? And what is that surgery? What are the results of their testing? Do we need to give them a prescription? What is their eye pressure? And then there's many things which take up our time, such as all the symptoms they may be having. And then there's things that, we often don't have any time to discuss at all, such as adherence, treatment cost, etc. So this is a nice strategy that my colleague has taken, which I think could be applied more broadly, where it's a follow-up on a approach that's been pioneered by Ecos Lamoureux and Eva Fenwick from Singapore and Australia, where they actually created this computer adaptive test, which asks people about many different aspects of their well-being and vision related to glaucoma. And then it gives them a nice score. So it tells them, how it tells you and them how they're doing in terms of comfort, activity limitations, mobility, treatment convenience, emotional well-being. And so you can see somebody over here, the treatment is not very convenient. So this is something that you can focus on. The question, maybe this can be part of the discussion that we have afterwards, is, how do you adjust for uncertainty across different populations? So, first of all populations have uncertainty about the patient's current state or their future state. So that's universally true. I think the more complex issue to deal with is that, in populations that have a poor ability or inclination to follow up, that does justify more proactive treatment, but at the same time, it doesn't give us carte blanche to do whatever we want for everybody. we still need to weigh the likelihood of not following up, the impact of not following up, and also the risks of treatment as well. So just because somebody, with ocular hypertension may not follow up, that doesn't mean they need a trabeculectomy, although maybe they need an SLT. And I think finally, I think it's still important to consider yourself as a resource. So, I think that all of you in India are really taking care of a lot of people, and probably for everybody you're taking care of, there's 5 other people who you should be taking care of. So, how do you not only regulate the number of people you see and make sure that you're seeing the right people, but if you're deciding to deliver a treatment that takes your time and effort, that you're allocating it to the person who's really going to benefit and not to the other person who wouldn't benefit, because you only have so much time to do lasers and the OR and everything else. And so you have to think of that as well. So looking forward to a good discussion, and thanks to you all for inviting me and having me.
Thank you. Thank you so much, Pradeep. I think people who have missed your lecture still can see in the YouTube later, but the live talk is so much of information that you have given to us. I think there's a lot of research questions in that, and I think people can really do especially a lot of people can do even thesis from your talk. So wonderful. Thank you so much, Pradeep. And we have 3 discussions today. Dr. Chandrima Pal, Director, BBI Foundation, Kolkata. And we have Dr. Gauri from Bangalore. She's the Director, Prabha Eye Clinic and Research Center. And then we have Dr. Kavita, Director, Glaucoma Services at Arvind Pondicherry. May I invite all the 3 of you for discussion? Over to you.
Thanks, Dr. Satyan. Go ahead. Thank you very much. That was indeed an excellent talk and opening a whole new world into glaucoma treatment. The way we look at starting treatment, the way we look at patients performing tests. So I was mesmerized by your talk. And what I'd like to ask you is that, do you think a level of IQ or intelligence or education is required for the kind of tests that you were talking about, say like 3 fields on the same day, or like the patient, talking about the symptoms of cloudy vision or missed patches? So how would you assess that?
Yeah, no, I mean, I always feel hesitant to tell people how to practice in a different setting, because, I've done so much work with the World Glaucoma Association, and even, I see differences in my practice from Baltimore to the suburbs of Baltimore, and then, what are the changes going to be when you go to a different country, and even within India, there's so much variation in terms of, what things are like. So, it's always hard to give people advice, for their own practice, because, things are very different, and, they have to, use their own IQ, right? And so, how patients are going to, process, kind of complex messages can be so different across different areas. I think maybe the one thing that I think they can tell you is how they see, That is one thing that I think probably is not that IQ dependent, and of course the word's different, and, in different languages, people may use different words. And so you have to use your local understanding of that terminology and jargon to understand it. But in general, people see things as whited out in glaucoma. That's the most common setting that they see. And so, here people will say cloudy, but then even that word can be a little bit inaccurate, because somebody will say they see cloudy. And I say, oh, does it look like there's a cloud there and that you're seeing the mountain through the cloud? They said, no, it doesn't look like that. And I said, oh, that's cloudy, right? Cloudy means that you're looking through the cloud, that like as if that like the cloud came down and now you're looking through that cloud. And so when you say that, they say no. But for glaucoma, they all say yes. That like, if there's if a cloud came down, if it's a foggy day and then like the clouds came low, then you're looking through that. That's what it looks like to them. So I think that probably is going to be relatively the same, But again, people have different languages and things like that. And so, it may differ for different people. But I think people can tell you whether their vision is good or bad, or, whether they're having more trouble. And probably a lot of people come in with glaucoma for that reason, especially advanced disease, right? Because finally they start noticing some of these things.
Definitely.
But, yeah.
Dr. Pradeep, you beautifully brought out that there is so much of art to the science of glaucoma. When, there's so much that is intuitive, and, when to step up, when to, stand back. There is, every time you're not very sure that you're taking the right step, but then you have to go by your intuition and, also monitor the patient. So there are, Dr. Satyan alluded to this in the beginning. There are certain practices that people do. See, this concept of central corneal thickness and risk of glaucoma. We all know that it is true in the context of ocular hypertension, as brought out by the OATS study. But then to overtreat by applying nomograms, I've seen that happen. Like, you correct for the CCT and say that this is always 4 higher than whatever reading we are getting by the applanation. And therefore, step up to surgical management or the next level of, treatment, because your so-called corrected IOP is out of the range. That also, I think, would qualify as a overtreatment. I would like to know if you see that as much in your setting. And definitely listening to the patient, I feel, is the most important thing that one can do. Fields, it is definitely not feasible in our context to do 3 visual fields or 2 visual fields in a particular visit. All my patients would just drop me and then go. They are not even happy to do the fields even once. So there are certain things that can be done in a research setting and probably not in our situation.
Right.
So do you see more of these CCT being applied in all contexts, which is not probably very scientific? Do you see a lot of that in your practice as well?
Yeah, no, 100%. Yeah, we do see it. I mean, and then I think that, that's, it really gets to the point that, while thinner corneas are going to undermeasure the pressure and thicker corneas are going to overmeasure the pressure, we know that's a fact. I think it's just, the confidence interval around how much they're undermeasuring it or overmeasuring it is so uncertain that you really don't know, what it is. And, and I think it kind of gets to the greater point also, is that, I mean, of course, I don't want to say that IOP is not important. IOP is very important, and, it's what we're treating. But, we have to be a little bit humble in the extent that we don't really know exactly what the IOP is. I mean, even applanation itself is an approximation of the, cannulation pressure of the eye, and people have not done a lot of studies to, where they've cannulated the eye. I mean, if somebody wants to do a good project, in the audience or there, it's a great project to cannulate the eye and objectively measure it and see how it differs in different people and populations, and, with different other, external measures of IOP. So, I think we have to have some understanding that these numbers are not absolute, and, and that we shouldn't be making, I mean, obviously if somebody's pressure is 30 or 40, you don't really have to think that hard. You need to get it lower. But, in kind of borderline cases, it's important not to overemphasize what IOP is, Yeah.
Kavita?
Excellent talk. Like for every slide, we get that robust evidence supporting each and every word of yours. That's like something we have to learn, and we have to start working in that line. As Dr. Gauri was mentioning about the central corneal thickness, which is often being measured and over treated in Indian scenario. I would like to have your opinion regarding the other commonly faced clinical scenarios, like maybe a large disc and a large cup, or maybe a glaucoma in myopia. And also there is under treatment are often missed glaucomas, like a small disc with a cupping, which is often missed. How do you go about this clinical scenarios? Can you just give some clinical tips to our people?
Yeah, I mean, here we have the, and maybe we do it too much, but, we have the assumption that people are going to come back, or that if you tell them they're going to come back, they're going to come back. I mean, and certainly the opportunity for them to come back is there. So if you say, okay, well, if somebody has a borderline case and you say, okay, well, I don't want to treat you, but you should come back. If they don't come back, then, in some ways it's their responsibility, because, there are people who have a lot of responsibilities or get sick or things like that, and they can't do it. But for the most part, there's no real excuse. I think there's parts of the world where you can't really say that. If somebody has to lose a day's labor or something like that, or, travel from a long distance, it's not fair to put them on them. They're like, oh, it's their fault. It's like you're asking them to do something which is harmful to themselves to come back. And so, you have to be a little bit more, you have to err a little bit on the side of, being more aggressive. I think with us, the thing that we see over here is OCT, because the OCT deliberately, tends to overcall disease because it doesn't want to miss anything, So, I mean, I think you mentioned myopia too, so that's the classic example, in myopia, especially if you're looking at the peripapillary RNFL, the circle is drawn bigger in myopes just because of a magnification effect. So, everything is going to look thinner. So, I think a lot of times people who are myopic come in. I mean, sometimes there's telltale signs. I mean, obviously you may know that they're myopic already just by looking at their glasses, but there may be other signs as well, such as the bundles being shifted towards towards the temporal aspect. But, oftentimes they'll have thinner RNFLs, and it creates more of a quandary. So I think that generally there are adjustments that can be made, but you have to be, especially if somebody is kind of -5 or above, you can't overcall the OCT to justify treatment. And so you have to be very mindful not to be aggressive on treatment in those cases purely based on the OCT.
In one of the papers that you alluded to, I'm sorry to interrupt, you were looking at a questionnaire or something which the patient reports. So to ask you, is there a patient-reported outcome measure that you would use on every visit of the patient? Just like, say, we check the visual field or the optic nerve head or the intraocular pressure, a standardized PRO tool which you could give to a patient and also take their perspective, apart from just listening to the patient tell us how worse or how good their vision or cloudiness or absent areas are. Do you recommend any of these patient-reported outcome questionnaires, or do you use any of these to get that from the patient as a variable each visit of the patient?
Yeah. I mean, that's a great question, and definitely a topic dear to my heart. I mean, I think that we need something like what this Glaucat that ECOS and Ava have developed, but probably realistically, I mean, that's very good for a research tool, and it may work for some practices if people do it online and it's delivered through their mobile and things like that, and they are willing to do it before they come in. But I think that practically, I think we need something which they can do fast and easily, right?
Yeah.
And then I think that a lot of the PROs deal very much with the consequences of poor vision, and of course they should, right? So they have a lot of questions on their mobility or their reading or their transportation or daily activities, things like that, which are of course extremely important. But then we're already treating those things anyway, so. Like, do we really need to ask about those things? Like, you don't really need to ask about those things because you're already treating all those things anyway. So you're addressing it. I mean, you may want to know whether somebody should, have rehabilitative services or things like that. So it may be relevant in that way. But I mean, I think what we don't ask is, do you have trouble remembering your medicines? Do you have trouble affording your therapy? Is it a huge financial burden to adequately, receive this care and proceed with this care? I mean, or do you have a lot of topical, symptoms from your treatments? I mean, like a questionnaire which really gets to these other things that we don't have time to address, honestly, that is really the questionnaire that, probably could be made, but is not really there in that format. But that's what we need. It's like, okay, well, because you're already going to address their visual well-being, right? I mean, that's we already do that quite well to the best of our ability, at least. But then all these other things, like, we don't even have time to ask about all these things. Are you putting in your drops correctly? Are you adhering to your drops? How much is the cost? Like, are you having any ocular surface symptoms? All those things. It's like, you don't have time to, ask these 7 or 8 questions. You'll be there all day asking all these things. So, but, can you get somebody to say, like, can you find the people who are really bad in those domains? Or, and ask a simple question, 5, 6 questions and say, like, okay, well, if they really voice a lot of displeasure in these things, can I have that conversation with them? because oftentimes there's things that we can do, right? Preservative-free medicines, laser to get off therapy, figure out if there's, ways that we can, make things more cheaper, decrease the level of follow-up. I mean, there's tangible things that we can do for a lot of these things, but we don't know, we don't have time to talk about it.
Manish, Dr. Manish, you have anything to ask? Dr.
So
Manish?
yeah, it was a very enlightening way of looking at things about the overtreatment and when to be more aggressive. But it is, as you said correctly, the patients are very keen to get tested. And then when you suggest aggressive treatment, they take a backseat. So now there is a lot of data which is coming out of various studies, which is recommending early treatment by SLT as a primary treatment. So what are your thoughts on that study and that approach?
I mean, I like it, because, it's, I mean, SLT, it works. I mean, I think there's always the idea that it doesn't work in Indian ice, and all of you can comment on that, whether it's true or not true, or whether the idea is still there. But, certainly in the population we're in, I like it, especially in, some of our resident patients, which is more of an inner city population. I mean, if you get the treatment in, then, even if they don't come back for a while, you know that they're doing a little bit better at least, because at least there's something that's still there. It may not work 100%, but at least partially works, and they have something on there to protect themselves from things. I mean, I think it is an art in terms of how we, describe these procedures to people so that they consider it to be agreeable. And some people may not want it, and it may be kind of very culturally dependent. I mean, over here, interestingly, a lot of the more educated patients want it, but then some people have a lot more distrust of the medical system, and they think that, oh, I'm doing a laser, I don't like that, so yeah, a lot of it comes in the communication of things. I tend to be I tell them that, like, oh, this is actually the one treatment that fixes the problem. All the other ones don't fix the problem. They're a Band-Aid on the problem. The problem is the trabecular meshwork, and here you're actually fixing the trabecular meshwork. I tell them, sometimes if I really think they would benefit, I'll tell them some facts about, medicines. I said, oh, it accelerates cataract, it does things like that, which are all true, So it kind of encourages them a little bit more in the SLT direction. But I mean, I think it's a good therapy. I think we should be considering it more often,
Dr. Tanuj has a question for you, Dr. Pradeep.
Oh, good.
So which type of fields do you use in your practice for follow-up of glaucoma patients? CETA faster, fast, standard, or the newer 24-2C? Which is the program that you prefer?
Yeah, well, hi, Tanuj. How are you? He and I are co-chairs for the World Glaucoma Congress, so we talk every day, or at least can email every day. I use CETA faster because I think it is more inaccurate, especially at the lower sensitivity levels. But if you look at kind of the global metrics of sensitivity, it's really quite similar, to the CETA standard. And then it's just, I think it gets us back to resource allocation, that, a technician can do, a CETA faster test on both eyes in, 15 minutes. And that includes everything, calling them in the room, entering the information, doing one eye, doing the other eye, and get out. They can do it in 15 minutes. Whereas with like CETA standard, it was like 25 minutes, and so like it's a big difference, and then the patients get tired. I mean, they don't actually get less tired with CETA faster. That's the one thing that I noticed, because it presents more stimuli which are close to the threshold. So it's better at presenting things closer to the threshold. So I thought patients would be much happier too, because it's a shorter test. But interestingly, it's just as it's the same amount of work that's more concentrated into a shorter period of time, So if you say like, okay, are you more tired after running 800 meters or after running 1600 meters? It may not that be as a race. It may not be different, because in 800 you run faster. So you get like, actually you have to like go more of a sprint. So you get like just as tired. In 1600 you also are tired, but then you run it slower. So, you may not be that different. So, but I do it mainly for the research standpoint. You can get more visual fields done in a day, and then usually visual field machines are expensive, and you can't have 10 of them for your office. You may only have like 1 or 2 or 3. And so, you want to get in as many tests as possible, and you may not have enough personnel to really run all these things. So the faster test is usually the right decision from a global standpoint.
Thank you. Thank you so much, Dr. Pradeep. I'm sure that we have many, many more questions to ask you, but as we have a limited time, first of all, our sincere thanks for you to accept our invitation and to be here with us today. And I think it's quite useful, that talk. Initially, I thought, what is this talk is going to be? But then once you went on with your talk, it was really, really very useful for all of us. I'm sure that many more people can see this in our YouTube channel sooner and get benefited. So once again, I really take this opportunity to thank you and all our moderators and our secretary and treasurer being there with us today. Thank you once again, all of you. And see you soon. And Pradeep, we are going to meet you soon at our GSI conference soon. Thank you so much. Thank you all.
All right. Take care.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Bye-bye.